A very good morning. So today we will be continuing, we'll bring a new chapter on major connectors. Today we'll be talking about mandibular major connectors. In the previous class, we had talked about maxillary major connector. So today we'll be learning the definition, the various types of mandibular major connectors, the indications, and the contraindications, and for which and how to choose the mandibular connectors for a particular situation. Coming to a major connector, the definition of a major connector, it is the unit of the partial denture that connects the parts of the processes located on one side of the arch with those on the opposite side. Types of major connectors. In mandible, we have around 6 types of mandibular major connectors, and they are lingual bar, sublingual bar, double lingual bar, lingual plate, labial bar, and swing lock design. So here are the examples or pictures representing the various types of mandibular major connectors. One is the lingual bar, the sublingual bar, which is beneath the lingual bar. You have the lingual plate, which covers the cingulum. Then you have the double lingual bar. Cingulum bar or the continuous bar is the same, almost the same. And then you have the labial bar, where you have the bar on the labial surface. The criteria for selection, the requirements for indirect retention, horizontal stability and stress distribution, anatomical considerations like mandibular tori, high frenulal attachment, wide embouchures, aesthetics, and contingency planning, and patient's preference factor. Functions of a mandibular major connector. It is to unite two sides of removable partial denture and distribute the stress, to unite the clasps with other components, to help indirect retention to an extent, and to splint weak teeth. Coming to the requirements of a mandibular major connector, it should be rigid and should unify the components, should be less bulky and strong. It should provide indirect retention, should help stabilization of weak teeth, should contribute to the stability, should distribute the stresses to the teeth when it comes in contact. Relief should be provided for the major connector. Coming to the lingual bar, this is an example of the lingual bar. It's the most common type of mandibular major connector. It is half pear-shaped bar with superior border located below the gingival border and the gingival margin. It requires at least 8 mm of vertical space between the floor of the mouth and the gingival margin. So the criteria for selecting this is you should have a requirement space of 8 mm between the floor of the mouth and gingival margin. And why 8 mm? 5 mm from the connector and 3 mm space between the superior border and the gingival margin. Now coming to the indications, where sufficient space exists between the elevated lingual sulcus and the gingival tissue, that is at least 8 mm. Below 8 mm, you can't give this. But stabilization or indirect retention is not required. This is how you measure 8 mm from the floor of the mouth. You can use a probe with serrations, which will tell you the markings, which has markings and which will tell you the amount of space present between the floor of the mouth and the superior border of the gingival or the superior of the gingival margin. So what is the advantage of these? It is very simple to construct, minimal contact with the tissues. It is hygienic. What are the disadvantages? It causes foot entrapment and patient discomfort if it is placed over an undercut. It cannot be used when tori are present. Chances of making it thin and flexible in case of insufficient vestibular depth. The design. It is half pear-shaped in cross-section. The superior border should be away from the gingival margin. The inferior border should not interfere with the movement of the floor of the mouth. The bar should follow the contour, but should not touch the mucosa. Superior inferior height should not be less than 4 mm. Sublingual bar. The major connector is the modification of the lingual bar. It is kidney shaped, placed deeper into the anterior lingual sulcus when adequate space is not available for the lingual bar. The indications: inadequate height of the floor of the mouth, anterior lingual undercut which requires considerable block-out. Contraindications: mandibular tori, high frenal attachment, high elevation of the floor of the mouth during functional movements, severely lingually tilted remaining natural teeth. Now coming to double lingual bar, it is also termed as Kennedy's bar or a continuous bar retainer. It differs from the lingual plate in that the middle portion is removed and the remaining is a superior and inferior bar. The lower bar is similar to the lingual bar. It is pear-shaped in cross-section. The upper bar should be half oval in cross-section with 2 to 3 millimeters in height and 1 millimeter thick. Just like the lingual plate, the upper bar should dip into the embouchures, and if a diastema is present, a step-back design is used. These two bars are then joined by a minor connector placed between the canine and the premolar. The rest must be placed at each end of the upper bar, no posterior than medial fossa of the premolars. Now coming to double lingual bar. Indications: actual alignment of anterior teeth, which brings about the need for excessive block-out of interproximal undercut, a periodontal disease resulting in large interproximal embrasures, a wide diastema in lower anteriors. Advantages: it provides indirect tension through its terminal rest. It provides horizontal stability by distributing stresses to all the teeth. Disadvantages: it's not comfortable for the tongue, and in case of crowded anterior teeth, it acts as a foot trap. Requirements of design: area between the two bars should be self-cleansing. Two bars should be attached by a minor connector located on the interproximal area. The end of the bar should be supported in prepared rest seat, downward movement and orthodontic movement against the anterior teeth. The lower bar is half pear-shaped in its cross-section, and the upper bar should be half oval in cross-section. The upper bar should follow the contour of the teeth above the cingulum, and the thickness should be around 1 mm, and it should be half oval shaped. To increase the rigidity, increase the thickness of the lower bar. If diastema exists between anterior teeth, a step-back design can be given. So we stop the class for this. We continue in the next class. The remaining portion will continue next class. Thank you.